Good morning. This is Carl Huang, and I've been sending out a medical update on what I think is the most relevant urgent care medicine topics for our department for the past few years. And I would like to try to do podcasts, but just a local podcast due to concern about patents regarding materials that I use. So we'll keep it local to our department. And this will be the first episode, and we'll try to keep it short, and so that you can just listen on the way home, and we'll see how it works out. And please give me feedback about how the podcast helps you and what I can do to make it better. So this is May 20th ReadyMed medical update, and I sent out the articles and the topics on April 30th, and I asked Sue, our office manager, to send out every month. So for the list of topics today, we start out with an interesting case of a 20-year-old woman with a sharp chest pain, and this came from Urgent Care Max uh, monthly podcast from EMRAP. So we have the 20-year-old woman present to the urgent care with sharp chest pain that worsened with rotation of her torso from side to side, and EKG show repolarization abnormalities with T-wave inversions in leads V1 to V3, and the axis and intervals were normal. And please refer to my email that Sue sent out on April 30th for the image of the EKG. But the point in this topic is that T-wave inversion in the precordial leads should prompt evaluation for anterior ischemia. And there is an evolution of EKG changes throughout childhood. And in utero, there is a right heart dominance until approximately 1 to 3 years old. And then this causes the right axis deviation with dominant S wave in lead 1 and dominant R wave in lead V1. And T wave inversions in lead V1 to V4 may be present. By mid-adolescence, approximately age 16, the EKG generally transition to normal adult findings. And T wave inversion may be seen in leads that reflect to rightward electrical forces, including V1, lead 3, and AVR. So back to the case, the EKG showed T-wave inversion in contiguous leads V1 to V3, but not reflecting ischemic changes since these T-wave inversions are shallow and asymmetric, with a slow downstroke to the nadir and a rapid upstroke consistent with a persistent juvenile T-wave pattern. Ischemic T-waves are typically deep, more than 3 millimeter, and symmetric, most common in young women of Afro-Caribbean descent, and 5 to 10% of this population. In this patient, the chest pain was not exertional and occur after a softball game in a young, healthy female patient without cardiac risk factors. So the low overall ischemic risk and patient were discharged. Differential to think about include arrhythmogenic, which can arise from right ventricular cardiomyopathy, and structural defects where the right ventricle is replaced with fibrofatty tissue, and T-wave inversion in V1 to V3, and hypertrophic cardiomyopathy is a second condition, which is left ventricular septal wall hypertrophy, which can lead to T-wave inversion in V1 and V3 with apical hypertrophy, and Brugada syndrome, which is arises from sodium channel abnormality causing pseudo right bundle branch block in V1 and V2. In these in physical exam, there could be a right heart strain causing T-wave inversions in V1 to V3, and occasionally in the inferior leads also. So that's the interesting case there about pediatric T-wave inversion in precordial leads to watch out for. Topic number 2 is a paper, and this is about diverticulitis. And a lot of the time we practice in medicine myth that hasn't been proven out. And in this case, it's about diverticulitis. The study is about nuts and seeds. Do they really cause diverticulitis? And this is a prospective cohort study of about 30,000 U.S. women aged 35 to 74 with no history of diverticulitis. 1,500 cases of diverticulitis were identified, and patient dietary intake of seeds, nuts, peanuts, corn, fruits, and fruit with edible seeds were quantified. And there was no association between intake of these food and incident cases of diverticulitis. Patients in the top quartile of healthy diet scores had reduced risk of incident of diverticulitis compared with bottom quartile of healthy diet score. DASH diet was also the best at reducing diverticulitis risk. So the National Institute of Health has removed its recommendation to avoid seeds, nuts, fruits, and popcorn to reduce risk of diverticulitis. The key is that if you want a patient to have reduced risk of diverticulitis, they just need to be healthier, along with what can cause reduced risk of cardiovascular disease will be cause reduced risk of diverticulitis and will help improve their immune response. And high fiber diet does not cause diverticulitis. It's actually very good for the patients and for us. So I also recommend that. Okay, so next topic, the latest on multiple myeloma. And this is from American Family Physician, March 2026. So just be quick on this here, and it's a big topic, but something to watch out for when in an urgent care setting. Quick definition is malignant disorder of plasma cells that overproduce monoclonal proteins. Epidemiology is 1.8% of all new cancer diagnoses. Risk is older age, non-Hispanic blacks, obesity, occupations as farmers, dresser, firefighter, or exposure to methylene chloride in Agent Orange. The pathophysiology is clonal plasma cells overproduce abnormal immunoglobulin or light chain proteins, leading to end organ damages and rarely hyperviscosity. Invasive bone lesions also result in hypercalcemia, bone pain, osteoporosis, and pathologic fractures. Anemia and immunosuppression occur due to bone marrow dysfunction. Risk of progression for monoclonal gammopathy of undetermined significance, MGUS, which we do see occasionally in patients' medical history. So the risk of progression of this condition to multiple myeloma is 1% per year. There are three factors that increases risk of progression. One is abnormal free light chain ratio. Two is non-immunoglobulin G and non-IgG MGUS. And three is serum monoclonal protein level more than 1.5 gram per deciliter. The presence of all three factors carry a risk of 58% progression in 20 years versus only 5% for no factor. Another condition called smoldering multiple myeloma, in which can progress to full-blown multiple myeloma. So serum monoclonal protein more than 2 gram per DL, light chain ratio more than 20, and narrow plasma and marrow plasma infiltration more than 20%. So 2-year progression risk is 6% without these risk factors and 63% with all three risk factors. Let's say 1/3 of newly diagnosed patients with multiple myeloma have documented history of MGUS or smoldering multiple myeloma. However, differential include plasma cell disorder, primary and metastatic cancer, hyperparathyroidism, and compression fracture. Presentation, bone pain, 58%, fatigue, 32%. Others include anemia, weight loss, acute kidney injury, hypercalcemia. Also, incidental lab finding and osteolytic lesion on imaging. Please refer to my email to check out the images, but it's just a clear, darker lesion on the bone. For labs, can be started for high suspicion at ReadyMed clinics, include CBC, plus smear, CMB, TSH, UA, and UPAP, SPAP for follow-up by specialists and with immunofixation, X-ray of symptomatic bony sites. Treatment include chemoradiation, proteasome inhibitors, biologics, monoclonal antibodies, steroids, autologous self-transplantations. Complications include bone disease, bisphosphonate for 2 years with calcium and vitamin D, infections due to immunodeficiency and use of immunosuppressant, so screen for HIV, HBV, HCV, and prophylactic antiviral, antibiotics, and vaccinations. Kidney disease, focus on support and working on with nephrology, and VTE risk increased by 9-fold, so low dose of Bixaban may be considered. Next topic, paper, viral panel plus antibiotic stewardship. I'm very big on practicing antibiotic stewardship due to high risk of antibiotic overuse for our population, especially in our urgent care practice, where we do see a case of viral illnesses every day. So in this paper, the object is to evaluate impact of rapid viral testing plus stewardship of antibiotic use and steroid use, prescribing 300 patients included, all tested with a viral respiratory panel plus antibiotic and steroid stewardship program, compare with seasonally matched historic control. So antibiotic use dropped after point of care viral testing from 38.2% to 24.3%. And steroid prescribing also reduced from 29% to 18%. 89% provider report high confidence in withholding antibiotic post-panel. So the editor's comments include study design not strong, providers not blinded, increase of cost of healthcare due to testing versus cost of antibiotic and steroid overprescribing. The result encouraged broader adoption of point of care viral panel to help reduce inappropriate antibiotic and steroid prescribing. It does help clinicians say no when antibiotics aren't warranted. Next topic, this from an urgent care rep from February of this year. Part one, this is about the cases. Case one, 15-year-old male with no past medical history, vaccinated with no recent travel or illicit drug use, presented with severe left-sided chest pain. Tmax in the urgent care was 103 and received 600 milligram ibuprofen from mom prior to arrival to the ED. Heart rate 136 at the urgent care 101.3, 97% of room air, blood pressure 109 was 71, respiratory 20, patient was ill but not toxic appearing, and no reproducible chest wall tenderness. EKG showed diffuse SD elevation and PR depression. Workup include a high sensitive troponin over 3600, CRP 8.1, set rate 18, white count 12.3, and rapid PCR show negative COVID, flu, A, B, and RSV. Patient transferred to the Children's Hospital. Case two, I remember seeing a case like this in a 17-year-old male when I was when working back at the Fallon Clinic about 12, 13 years ago, and sent this patient to UMass for further evaluation and treatment. Case two is 21-year-old male with 4 days of pulsating chest pain. Past medical history include traumatic injury to motorcycle accident, but no traumatic chest injury. No family history of any cardiac disease or sudden cardiac death. Physical exam 139 over 85, heart rate 85, temp 99.7, 97% of room air, respiratory rate 23, and EKG show SD elevation in inferior and lateral leads. Workup again, troponin over 3600, no leukocytosis, and very mildly elevated inflammatory markers and negative PCRs and chest X-ray. Echo show normal and left ventricular ejection fraction and myocardial contractility without regional or local or focal wall motion abnormalities. MRI show pericardial thickening enhancement with subtle myocardial and subpericardial enhancement, most pronounced in the apical inferior segment, suggesting myocarditis. This position include follow-up with cardiology with echo and discharge with colchicine. That's part one, and we'll go back to part two later on. For smoking cessation counseling in acute care setting, urgent care wrap, February 2026, we do have a unique opportunity in the urgent care setting to take small opportunity to turn them into life-impacting changes. The simple act of asking about tobacco use opens up the conversation to discuss smoking cessation. I've had a really good response from patients with history of smoking. I would say about more than 50% of the time they did say they do want to get help. Again, they may be non-compliant or they just wanted to please me and telling me by telling me so, but it's still a pretty good response. And I've had patients coming back saying that, thanking me for helping them with quitting smoking in a later visit when we met again. I told patients all the time, kindness, yes, we can help them sleep better without medication and so on, and provided reassurance. Use that as an opportunity to help them quit smoking. And that is a much bigger deal. Can prolong their life by several years and help improve quality of life for them and their families. So it's worth spending 5-10 minutes, especially when bronchitis treatment workup, and it's only about a few minutes of your time. So even if a patient isn't ready to quit, opening the conversation increases the chance that they'll consider quitting in the future. Use a non-judgmental, stigma-free approach to create a safe environment for discussion. And it's interesting too, when after they say, no, I'm not ready to quit, I say, hey, it's cool. I ask everyone, and if you're not ready, that's perfectly okay. And when you're ready, talk to your primary care provider, or you can talk to me. So first line treatment is nicotine replacement, 1 milligram per cigarette in general, or one patch for 24 hours. And depending on how much the patient smoke, you can replace with the equivalent amount of nicotine. You can use the gum or lozenges also for breakthrough. And do not swallow these. Combine Just make sure you either put under the tongue for the candies or the gum. You chew and then suck on it, chew and suck on it until it goes directly to the brain, to the mucosa, oral mucosa. You can combine the patch and the lozenges and gum, and Mass.gov provide free counseling and nicotine replacement products for the patients. I've had patients requesting these from Mass.gov and was able to get these within a week. Writing scripts may reduce cost of nicotine also. So where Varenicline or Chantix is a partial nicotine agonist, you can do smoke and taper over 4 weeks. It could cause vivid dreams and nausea, vomiting, constipation, and not in those younger than 18 years or pregnant women or severe chronic kidney disease. FDA has removed the black box of suicidality for Varenicline. Bupropion, the additional benefit of bupropion is can help elevate your mood or help with depression, some weight loss and cravings. And in some patients, can also boost their libido. And again, you can have them take bupropion and cut down slowly, and you can use that with nicotine replacement products. Picture quiz: persistent hypopigmented rash on from American Family Physician. So this is there's a picture on the the email I sent out. 11-year-old boy presented with a rash on his back, abdomen, arm that had been present for several years. The rash was non-pruritic. The patient experienced occasional irritation. He was previously treated with ketoconazole cream without improvement. Topical hydrocortisone moisturizer were also ineffective. The patient's mother reported he was otherwise healthy and growing well. Exam revealed a well-demarcated hypopigmented macules and macula and patches that were coalescing on his back, abdomen, buttock, medial upper arm, and posterior thighs. Some of the lesions had mild erythema and overlying scale, and a few subtle atrophic. A hypopigmented lesion on his right posterior thigh showed erythema with overlying scale and follicular prominence. With lab evaluation showed hypopigmentation. Biopsies of two representative lesions were obtained. So based on the patient history, which one of the following is the diagnosis? Atopic dermatitis. Do not think so, because it's due to the chronicity of the condition and failure to conservative treatment for many years. Hypopigmented mycosis fungoides is a possibility. Tinea versicolor, he failed antifungal, and again, duration also could be fungal. So that's a possibility. And then vitiligo, which does not look like that, since the hypopigmentation is not as sharp as a vitiligo. So the answer is hypopigmented mycosis fungoides, and this is a cutaneous T-cell lymphoma. It's the most common variant of mycosis fungoides in children. Typically present with persistent round to irregular hypopigmented non-atrophic patches with overlying fine scales. Follicular lesions may also be present. The patches usually appear on the trunk, buttocks, and limbs. They are generally asymptomatic but may be mildly pruritic. Biopsy is required for diagnosis, and multiple biopsy from different lesions may be necessary. Cutaneous lesions are often the only manifestation of hypopigmented mycosis fungoides, and treatment directed at the skin are typically effective with favorable prognosis, including phototherapy, immunotherapy, UV radiation therapy, and chemotherapy. Topical treatments such as corticosteroid, retinoids, and histone acetylase inhibitors are also effective. Two other differential to consider is idiopathic hypomelanosis is a possibility, and then the other one is dyschromia. Dyschromia is from overgrowth bacteria in certain part of the skin, causing uneven skin coloration, and the treatment of that could be some cleaner gel or narrowband UV light. For idiopathic hypomelanosis, you can use selective tanning method. Okay, another topic. This is pretty important, and we can encounter it in the urgent care is menopause, and called EMRAP, January 2026. Menopause, by definition, is 365 days after the final menstrual period. Perimenopause is every day before this, and postmenopause is every day after. Average age in the U.S. 51 years old, but lower for African and Asian American women. In perimenopause, there are not enough eggs to respond to the signals coming from the brain, leading to resistance, causing more LH and FSH production by the hypothalamus. And FSH and LH can be ordered to confirm diagnosis. Near the end of perimenopause, anovulation occurs, which leads to unopposed estrogen, and cycles become heavier. Many patients in perimenopause went through unnecessary cardiac workup for palpitations. The effects of drop in level of estrogen lead to 40% increase in mental health disorders across perimenopause transition. Estrogen binds to CNS neurons, affecting level of serotonin and dopamine, causing mental health symptoms. Musculoskeletal pain, since estrogen is a powerful anti-inflammatory hormone. Recurrent UTI and dyspareunia due to vaginal dryness and reduced mucus secretion is also a common symptom. And this can happen years after menopause started. So treatment of choice for these women with recurrent UTI and dyspareunia, and the condition is called GUSM, genital urinary syndrome of menopause, is vaginal estrogen. You can use 1 gram estradiol 3 times a week, and you don't use antibiotic. And this does not increase VTE and breast cancer risk in these women. Also does not increase CVA risk. For hormone replacement therapy, either oral or using estradiol patch, the risk is VTE, so to be avoided for those at higher VTE risk, venous thromboembolism. Benefits is cardioprotective for 10 years after menopause and reduce osteoporosis. I like the patch the most. I think that it works almost very soon, right after maybe a day or so, and the women feel the effect. Reduce hot flash, irritation, insomnia, sometimes palpitation, improve musculoskeletal pain control, and it's just so many benefits, and it's so important to recognize in women near the menopausal age to consider, and you can potentially really help make a difference in their life quality. Paper, nasal acetylene to prevent viral URI is the urgent care wrap article in January 2026. So they did a study where they administer nasal acetylene 3 times a day to reduce COVID-19 and other viral URIs. 450 participants included. So the COVID infection reduced to 2.2% versus 6.7% for placebo, and odds ratio is only 0.31. For longer time to infection, it's 31 days versus 19.5 days. So the other viral URIs is 9% versus 22% for the control group, with odds ratio of 0.4. So the editor's comment is, this is inexpensive and it's safe, over-the-counter preventive treatment for COVID and other viral URIs. So for those that have at high risk, those with occupational exposure, something worth considering to help reduce the risk of having multiple URIs throughout the year, this cold season. Approach to croup using Wesley score, croup score in the urgent care. American Family Physician, March 2026. Wesley, Westley, can easily be found on MD Calc on Google. So the Wesley Croup approach include chest wall retractions, stridor, cyanosis, level of consciousness, and air entry. So 5 categories, and a score of 2 or less. They recommend dexamethasone and discharge with return precautions. Score of 3 to 7, oxygen if needed, racemic epi, nebulizer treatment with dex and antipyretic. And there's a chart too in the document in the email that I sent with regarding the algorithm for using the Wesley's group score to help manage your group to patients. And then so in this medium risk group score of 3 to 7, it may involve observation for several hours. If you decide to send the kid to the ED, nobody can complain about that, because you have to administer oxygen, nebulize epi, and then dexamethasone, and then you assess response after 30 minutes. If there's positive response, you observe for now 2 to 4 hours. But if moderate severe symptoms recur, then you repeat the treatment. But by then, if you say the clinic is slow, you can consider doing that. But if it's busy, then just send the patient in this group to the UMass ED. Excuse me. And then with a score of 8 or higher, you can send to the ED for likely admission and the same treatment as above. Myocarditis Part 2. For the definition is inflammation of myocardial tissue. The prognosis is 50% full recovery, 25% chronic cardiac dysfunction with reduced EF, and 25% can deteriorate into cardiogenic shock and death. So I ran into a case when I was in the Navy with a young Marine, 19-year-old, running 3-mile under 19 minutes. Very impressive fitness, and developed acute shortness of breath and found to have diagnosed with myocarditis. And EF came back with only 15%. So ended up needing a cardiac transplant. Is pretty impressive with the presentation and the prognosis and how severe this can get. And it's just very, very unlucky. So a lot of these patients recover fully, and that's fortunate. So the causes could be autoimmune, such as connective tissue disease, giant cell arteritis, sarcoidosis, hypereosinophilic, and it could be also infectious, toxic. Infectious, pretty common with a viral, toxic, and drug hypersensitivity. Presentation include chest pain, so that's why ACS need to be ruled out, and share symptom with pericarditis, fever, elevated CRP. Heart failure may see both left-sided with pleural edema, orthopnea, and right-sided symptom with elevated JVP, nutmeg liver, hepatosplenomegaly, and minor to severe shock and presentation, arrhythmia with palpitation, syncope, and sudden cardiac death. Workup includes EKG, troponin, echo, cardiac MRI, which is the gold standard, CBC to look for possible eosinophilic myocarditis, ED transfer for concerning EKG, persistent tachycardia, elevated troponin, sign of cardiogenic shock, and concerning arrhythmia. Low-risk discharge include normal vital sign, reassuring EKG, and cardio follow-up arranged. So if you're not sure, you can always check with our cardiologist, colleague, to see whether it's safe to discharge this patient and follow up with them in a few days in outpatient setting. Normal vital sign, reassuring EKG. Follow up, no strenuous activities for 3 to 6 months post-diagnosis, clearance after normal cardiac MRI, echo, stress test, and rhythm monitoring. Last topic is paper, patient satisfaction score, and medical decision making in the urgent care. Urgent care RAP, January 26th. It's a pilot study showing that the use of patient satisfaction score may be associated with a negative impact on medical decision making. 42 provider with 20 responses over 4 weeks, 100% confirmed employee use of PSS. And we know that Optum uses PSS and you get a bonus on incentive having high PSS score. 85% reported PSS impacted compensation or promotion. 45% reported employers did not clearly communicate how score contributed to evaluations. And 70% alter treatment plan, and 65% changed patient interaction due to patient satisfaction score. Only 15% found the PSS improved medical decision making. 90% believe score were unfairly determined and used. The findings is that limited size study and subjectivity, but does reflect widespread concern about PSS distorting clinical care. Further research is warranted, but this is highlight conflict between evidence-based care and patient appeasement. So I hope you find this helpful and saving time for you to listen on the way to work, or on the way home, maybe on the way to work. Probably too much to after a long shift to listen to this, and I will bore you to death and you fall asleep and crash. So maybe on the way to work, listen to this. And if it's too compact, then maybe consider listening again second time, because I've done that many times. And I feel like the second time, I even take in more. So any feedback, let me know, email, text me, and appreciate it. And we'll see how this worked out. Thank you so much for tuning in. Take care, everyone.